Assalamu alaikum. My name is Dr. Huma Asghar, and I was asked by Dr. Shahid to give a brief presentation on psychological factors in obesity management as well as in obesity as a disease and all the factors that contribute to obesity and make it such a challenging condition to deal with. We generally think of obesity as a biopsychosocial disease, meaning that it is caused by an interplay of biological susceptibility um, in combination with certain behaviors that arise directly from psychology. And the third element is environmental, which may constitute triggers or constraints, which make it easier or more difficult for people to maintain their weight, lose weight, gain weight, or to follow certain kinds of behavioral modifications on a consistent basis. It is no surprise to anyone that there are multiple psychological drivers of obesity. Anxiety, depression are obvious factors, but also underlying diagnosed or undiagnosed neurodiversity, for example, ADHD or autism, may play a significant role. For instance, people with ADHD may find it exceptionally difficult to follow routines and rhythms and to maintain habits. Conversely, people who are on the autism spectrum, even if they're undiagnosed, may find it very hard to deal with flexibility or changes in their routines. And therefore, what may be working well for them for a certain period of time may no longer work if circumstances change. A history of trauma, which may be shared with the clinician or may not be shared, which may be in the past or it may be ongoing, makes it extremely hard for people to lose weight, but also to institute the kind of behavioral changes that would lead to a healthier weight and a healthier lifestyle. A very large proportion of people with obesity will have disordered eating patterns, sometimes with to the extent of reaching a formal diagnosis of eating disorders. Issues with executive dysfunction can often make it really hard to plan meals, to follow routines and structures. Furthermore, people may develop certain kinds of identities that they may hold on to very steadfastly, and that makes it really hard for them to change their behaviors. These include statements like, I am not an exercise person, or I am addicted to sugar, or I couldn't possibly give up dot, 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 whatever it may be. We also have to remember that very often food, especially highly processed, hyperpalatable foods, may be used as coping mechanisms to deal with any variety of unpleasant negative emotions that people may or may not be conscious of. And all these may be in the background when somebody comes to us for a prescription for tirzepatide, for instance, or any weight loss medication. We don't have to be psychiatrists or psychologists. We don't have to necessarily diagnose or treat all of these conditions, but we do have to be aware that these are probably lurking somewhere in the background because there's a reason this person in front of you has struggled so much with implementing the kind of a lifestyle that would have led to a more to a healthier weight. Food can often and is often used as a form of as a tool for emotional regulation, and here it can serve the same purpose as alcohol or tobacco or many other substance and behavioral addictions can. So very often we have to realize that food may be a coping mechanism for boredom or anxiety or depression or a sense of being in an unhappy situation. Some people may turn to social media. Some people may turn to gaming addictions. Some people may turn to other kinds of numbing behaviors, and very often food is used in the same category. sometimes we have to be aware that if we put people on medications such as the GLP-1 receptor agonists that take away their drive and pleasure for food, sometimes we leave them without a coping mechanism, and that can occasionally be very distressing to patients. It behooves us to do a quick screen for eating disorders or disordered eating behaviors. And there's some simple questions to ask for. Do people feel that they have absolutely no control over their eating? Are they skipping meals? Are they hiding their eating behavior from other people? Are they eating in secret? Are there very rapid changes in weight? These people do need help, but if they screen positive on some of these factors, um, we need to tread with care, potentially get a psychologist to help if possible. If that is not an option, then we would be better off focusing on a gentler regimen, avoiding undue or excessive or very rigid rules around eating, focusing more on developing routines and rhythms rather than the kind of eating behaviors which would be associated with, for instance, calorie counting or time restricted eating, because that can be a very slippery slope for people with eating disorders. How do we put it all together? How do we do this in practice? The first thing is to meet people where they are, to assess their readiness for change, to assess their bandwidth, to see what they are currently doing, what they're capable of doing, and what they're willing to take on. There is no one size fits all, you know, answer to this. So our approach to our patients has to be individualized based on where they are and where they're willing to go. We generally start with motivational interviewing, which is basically a measure to assess the patient's own readiness to change and to let them drive the process. The idea is to have them develop a sense of self-efficacy, to understand that to first get a sense of where they are, to meet them with empathy and curiosity, and to help them identify the discrepancy between where they are and where they wish to be, to acknowledge the ambivalence, and to help patients develop the plan and path forward while we provide them with support. Cognitive behavioral therapy depends on the realization that our thoughts, behaviors, and actions are all interrelated. And while thoughts can impact behaviors, can impact emotions, these changes can work in any direction. So therefore, the most common way to address this is to identify people's automatic thoughts. And automatic thoughts may be anywhere from black and white thinking. I had a large meal, I had two desserts, two servings of dessert for lunch. Therefore, I have fallen off the wagon and I might as well forget about trying again. It's a classic example of black and white thinking. Or, if some certain foods are good, certain foods are bad, I have no willpower. There are certain thoughts that people often come up with, and it is helpful to help them identify them, reframe them, and then find things that patients can do to break those automatic patterns of thoughts, feelings, and behavior. Acceptance and commitment therapy relies on patients identifying their own values to see what's important to them. When somebody comes to you and says they want to lose 50 pounds, the question is why? So it helps for patients to identify their own values. It may be because they don't want their knees to hurt anymore. It may be because they want to be able to play with their children or grandchildren. It may be because they want to be able to exercise more or sleep better. But they have to be values and motivations that are true to patients. The next step is to understand that there may be discrepancies in whatever their behavior is and where they are, to accept that things are not perfect, and then find a course of action that patients can commit to. This is what something like this might look in practice. We're looking at a few different scenarios. For instance, the people with ADHD, whether or not they're diagnosed, they have major problems with maintaining consistent routines. We might want to see where they are at this point. What is the most predictable part of the day for you? Motivational interviewing would help clarify what they are most interested in, what they are most concerned about. They may be dealing with all or none thinking, which is also called black and white thinking, that if they're exercising like 5 days or 6 days a week. And if they are not exercising, then they just don't do it. So we help them find a balance. We help them find a way of being comfortable with less than perfect outcomes and less than perfect processes, and an acceptance commitment, an ACT-based therapy would include diffusing their thoughts. For instance, if they have a feeling that I am just not an exerciser, then making peace with that statement or diffusing the power of that statement would be, I'm getting these thoughts. So my brain is telling me the old story that I'm not an exerciser, but I can dot, dot, dot. You take over some of that agency and say, well, yes, I'm getting that idea, but is that really true? Does that really mean that at no point in my life can I become more physically active? And then you take it from there. So the more, for people with depression, they may not have motivation. So we would have to see what their current energy level is, what their current motivation is, and start with something very small. We might want to ask them, well, if you don't have energy, what is what would more energy allow you to do? What would make it more important for you? What would make it more pleasurable for you to do? And we might focus on behavioral activation, something very small that is in their power, that is not overwhelming for them. So these are just certain examples. One of the very important things to focus on is to go with processes rather than outcome-based goals. So for instance, rather than saying, my goal is, or your goal is to lose 10 pounds in 3 months, it would be, well, your goal is to do something that's in your power. You don't have power to lose 10 pounds, but you do have power to say, okay, I'm going to have 5 servings of vegetables this week, or I'm going to go for a 5-minute walk 3 times this week, or I'm going to have a protein at breakfast 4 days this week, or anytime I am tempted to have a snack between meals, I'm going to take a 2-minute pause and then decide if I want to have that snack. So these are very small habits or very small commitments, but the idea is to set up a goal that patients can easily achieve, because that's what's going to give them confidence, and that's what's going to give them a sense of agency that they can do this. For this, we rely on what we call SMART goals, which are specific, measurable, achievable, relevant, and time-bound. For instance, like we said, a 5-minute walk 3 times a week. That's a very specific, measurable, achievable, relevant, and time-bound goal. Once people are consistent with a small goal like this, like walking 5 minutes 3 times a week, and they can consistently do it, it becomes automatic week after week, then we can increase that and we can layer on a second goal. For instance, I'm going to have fruit with breakfast 3 times this week, in addition to walking 5 minutes 4 times this week. Weekly check-ins are very helpful, and the importance is that this should be without shame. And the weekly check-ins are really used as a way of getting data that is helpful for the patient as well as for the person providing the accountability. You track one thing and you adjust it daily, adjust it every week. So if our goal was that you're going to walk 5 minutes 3 times this week, and the patient comes and says that they haven't been able to do it, and they only were able to do it 2 times, or they were only able to do it 1 time, you might want to just adjust that goal. You might decide whether to maintain that goal, to keep it, or to drop it down. And only when they're consistently doing it 3 times a week for a few weeks, then we can increase it to 4 times a week or to 10 minutes 3 times a week. But we want to make things very simple. We have to remember that behavior and biology works together. And this is particularly important in people who are on GLP-1 or similar medications, because the medications will affect the biology, but it is not necessarily going to affect the behavior. So we want to use that opportunity while biology is working in their favor. We want to use that opportunity to help them readjust, recalibrate their behavior to set them up for long-term success. We have to frame our medication therapy, or in fact, any therapy for weight management, as being a chronic therapy for a chronic disease. Just as we would have somebody with hypertension, we would expect them to be on antihypertensive medications long term. Very similar to that, with somebody who's getting treatment for obesity, we would normalize to them that they would need this treatment or this way of eating or this way of exercising for the rest of their life. We also have to remember that with GLP-1 receptor agents, there is a decline in in deriving pleasure from food. And there is a crossover where people sometimes report that they do not get pleasure from other pleasurable activities as well. And that can be very distressing, and this can actually manifest as newer onset depression, which didn't exist before, partially because the use of food as a coping mechanism has been taken away, and also because it does reduce dopamine-directed behavior and motivation and pleasure. So it's important to watch for decline in mood with GLP-1 receptor medication use. We want to think of sleep and movement as psychological tools. It is very important to remind people that exercise is not a way of burning excess calories that they had. It's not a way of balancing out their caloric intake or of losing weight. Rather, exercise or movement is more for emotional regulation and improvement in sleep. And better sleep leads to better impulse control. So super, super important to stress upon the need for more sleep and better quality sleep. Very often when patients come to me, even before I talk to them about nutrition or cutting back calories or anything like that, I first insist that they get enough sleep. This is a very quick one about stepwise goal setting. Basically, is what we said earlier. We want to identify the patient's point of least resistance. What is it that is easiest for them? We don't want to go with the most important thing or the most difficult thing. We want to go with the easiest thing that they're potentially already doing, that they feel comfortable doing, and then lean into that, because the goal is to get them to develop a sense of confidence and mastery and self-efficacy so that they can feel confident, and in turn they can change their sense of identity. We always want to choose one behavior, never a category. So if somebody says, I need to eat better, eating better is too vague, it's too widespread. So what we want to say is, okay, what does eating better look like? Eating better looks like having protein with having protein with a meal. So maybe you're going to focus and get at least 3 meals this week with protein. and then you can increase it from there. But you start out with one behavior, or one behavior is going to be, if somebody is having orange juice with breakfast every day, we say, well, okay, one behavior is going to be to have orange juice only 3 times a week. So just one very discrete behavior, and we're going to use the SMART tools like we talked about before. Also, if we decide that we have set our goal as a 5-minute walk 3 times a week, we say, okay, what's the worst week scenario? What's going to happen? Do you think if things are really bad, you're having a very stressful week, you will be able to get those 5 minutes 3 times? If you won't, then we'll drop down the goal to 2 times a week. You only track one metric, adjust every week, and we only layer on another goal when the first goal is automatic. We want to build a ladder, not a mountain. We want to make it easy. We want to make the steps so small that they become simple and automatic, and you don't have to work with willpower. It just becomes automatic and easy. You always want to celebrate the process. We always want to celebrate the path of how consistent somebody has been, not the outcomes. And we don't want people to be attached to the outcomes. We want people to focus on the processes, because that is what gives them a sense of mastery. So the 4 pillars in this process would be, first of all, to stabilize, to make sure when people start coming to you, they might be quite dysregulated. Make sure they're getting sleep, they're getting 3 meals a day, they're not, their mood is reasonably regulated. You understand where they are, individualize and provide them support. So GLP-1s treat biology and psychology treats behavior, and you have to do both. And one danger of using GLP-1 drugs to effect very aggressive weight loss is that as people see their weight coming off, they do not necessarily feel that motivated to change their behavior, which is disastrous for their metabolic profile in terms of skeletal muscle mass loss if they're not exercising. And also, it doesn't help them cement the kind of habits that would work for them long term. And it doesn't ensure that they're getting high quality food with vegetables and protein and unprocessed food. So success in this context looks like somebody who's having fewer binges, more stability, better mood, more self-compassion, and more consistency in taking small steps, because rather than big dramatic changes, smaller steps taken consistently are more likely to lead to good long-term outcomes. We do know that anytime people lose weight with yo-yo dieting or with GLP-1s, with medications, we lose fat mass as well as fat-free mass, that is like skeletal muscle mass. And with weight regain, fat mass is regained preferentially. So anytime there's a cycle of weight loss and weight regain, in essence, we are trading some muscle for fat. And when this happens repeatedly, this is extremely detrimental to patients' body composition. So the takeaway is that our patients don't fail treatment. Our treatments fail to address the whole human experience of heart, mind, spirit, and body. And we cannot provide our patients the kind of help we would like to unless we cover all these elements in addition to just the medications. We also have to remember that these GLP-1 or GIP-based medications are only one tool in our toolkit, making sure that people are getting enough sleep, they're screened for sleep apnea, treated for sleep apnea, and any associated, especially depression or anxiety, are addressed with pharmacological measures if need be, in addition to or in conjunction with the use of these injectable weight loss medications. Thank you for all you do for your patients, and thank you for giving me this opportunity to speak with you all.